The next presentation, that is PSC, primary sclerosing cholangitis plus cholangiocarcinoma, the aspirin trial. And we have Dr. Simon Rushbrook from the University of East Anglia. And we have also Professor Shahid Khan from Imperial College London.
Thank you. So the next 10 minutes, I'm going to try and give you an update on PSC, a disease we've talked about quite a lot at this meeting. So for those of you that don't know, PSC is one of 4 autoimmune conditions of the liver that essentially can affect the biliary tree from the smallest bile ducts, in which case we diagnose it by doing a liver biopsy to see those small ducts, and we call it small duct PSC, but it has a propensity mainly to affect the large bile ducts of the liver, in which case we call it large duct PSC. And to diagnose it in terms of large duct PSC, we generally look for changes on the shape and the anatomy and the uniformity and the appearances of the biliary tree, doing a technique called MRCP, where we go from a nice smooth bile duct to this irregular pattern called a cholangiopathy. And it's important as part of that process of diagnosis, we exclude other diseases that can mimic PSC and be sure we've got a confident diagnosis. Now, although we have good, robust evidence that it's an autoimmune disease based on the risk genetic profile that seems to be causative in PSC in terms of the genetic component of the disease, we don't yet understand if there's a genetic component that drives the cancer risk. And like all autoimmune diseases, it has a very strong HLA association. In fact, that's the strongest genetic risk loci for PSC, centered over HLA-B8. But the unusual thing about PSC is that about 75% of patients have an associated inflammatory bowel disease, and the phenotype of that is both genetically distinct, it's clinically distinct, it has about a 4 to 5-fold elevated risk of colorectal cancer compared to IBD with non-PSC. And in terms of the phenotypes of colitis you can see with PSC, there's the UC phenotype, there's the Crohn's phenotype, and the indeterminate phenotype. Although how we define those, particularly in PSC, is not as robustly worked out as IBD without PSC. Now, in terms of the pathophysiology of PSC and its association with cancer, there's some very unique things going on. The biliary tree is under heavy immunological attack from both the innate and the adaptive immune system. There is alterations in the fungal component of the microbiome and also the bacterial component living in the bile ducts. And both of those stresses seems to put a huge stress on DNA mutational patterns within the DNA of the cholangiocytes. And in fact, the cholangiocytes in PSC seem to protect themselves by entering this senescence-like state, which is a state to protect their genome. And I suspect in PSC, it's that escape from senescence, which is the early cellular state that allows us to move on from normal cholangiocytes to low-grade and high-grade dysplasia. Now, in terms of the epidemiology of PSC, that's relatively been beautifully done by various groups. And one of the nicest papers, I think, is the paper from the Netherlands group that showed this excess SMR associated with PSC. And you can see within what's driving that SMR is high risk of cholangiocarcinoma death. But there's also some important messages. This was a paper that came out from nearly 7,000 patients collected by the International PSC Study Group that showed there are risk factors for cancer within PSC. We know that small duct has a lower risk than large duct. We know that male sex is important, that messaging of the importance of your sex and your cancer risk. And we know that this risk increases longevely over time. More importantly, if you have Crohn's associated with your PSC, you seem to be of lower risk of hepatobiliary cancer than ulcerative colitis. Another little interesting thing came out of the registry data from Europe that you can see patients with UC alone are developing perihilar who have not been diagnosed with PSC. And I suspect the reason for that is within our colitis clinics, unless we've detected PSC, there is a group of sort of what I would call a sub-PSC phenotype that are lurking, that have that cancer risk. And because their liver tests haven't become abnormal, we haven't detected them yet. Now, we've learned a lot about PSC in terms of the epidemiology. We know that about 1/3 of people who get cancer with PSC present within their first year of diagnosis. We know that in the UK that the surveillance strategies to look for cancer are very heterogeneous. And we think in terms of diagnosing cancer, MRI is a better tool than ultrasound. And there has been a huge amount of debate. In fact, if you look at a lot of the guidelines, they are subtly different what they say about looking for cholangiocarcinoma in PSC. But retrospective data from the Mayo, retrospective data from the International PSC Study Group suggested that if you were surveying your patients using some sort of surveillance, whether it be ultrasound or MRI, you had earlier detection of biliary tract cancer and better outcomes. But as all things, this wasn't prospective data. And one reason for doing surveillance in the UK and other places is there's now this new indication that if we could detect cancers early, small perihilas less than 3 centimetres or small intrahepatic cholangiocarcinomas less than 2 centimetres, there could be a new treatment option for these patients. But unfortunately, a large prospective, which was a recent study published from the Sweden group that looked at nearly 500 patients, did not show that patients undergoing annual MRI and annual CA19.9 had a lower risk or an earlier detection risk of cholangiocarcinoma and a survival advantage. So I think the jury is out on the best way to survey these patients, and therefore other markers come into play. I think there are unique challenges when we deal with PSC and cholangiocarcinoma because in terms of investigating changes in the biliary tree, mainly driven by functional changes in symptoms, there are some unique challenges. ERCP is often exposed to patients that have a change in morphology of strictures and a change in symptoms. But the problem is this is a high-risk technique. You've already heard from Chris about the risks of ERCP, or the risks of ERCP are even higher stakes in patients with PSC. And one of the problems is a technique that we often use to scrape these strictures, looking for cytology, is highly inaccurate. In fact, it's like flipping a coin when you look at the sensitivity of the test. Other new evolving technologies to try and detect cellular aneuploidy, such as using FISH, have not really taken off in the UK. And in addition, new techniques such as spyglass cholangioscopy, where you can drive up the bile duct, are very problematic in PSC. I do a lot of this in my institution, and the problem is when you look at cholangios in non-PSC settings, they're very defined. You can see the change from normal to abnormal, but when you're driving up a bile duct that looks like this, it is very difficult, in fact impossible, to know where cancer starts and inflammation ends, and therefore you end up taking a series of random biopsies pretty much to try and diagnose it. One hopes that genetics may have a role in moving things forward for patients with PSC. There's large swathes of patients now that have been genetically sequenced, and we've seen some of these key genomic targets that have highlighted in other talks. They're very similar to the perihyla. And in fact, one thing that I think might be useful is this move to next generation sequencing of bile. If you're going to do an intervention in a patient and try and see if there is a cancer hiding away in a stricture, perhaps next generation sequencing on the bile fluid itself might provide some optimism in improving our diagnostic rates when we're doing intervention in these patients. There is a move now in other papers to look at methylation signals within bile with good outcomes in PSC for diagnosing cancer. And finally, perhaps going back to our brushings that are so problematic in diagnosing cancer in PSC, if we apply next generation sequencing to those biliary brushes, we might improve our diagnostic rates. So, in conclusion, I know it's very rapid, PSC is an inflammatory condition. About 18% of people will get a cancer. I think at the moment how we survey this population has yet to be determined, but perhaps we might be better if we try and stratify down to those with severe biliary changes, male patients, large duct and UC, and next generation sequencing on bile and eventually blood might hold some of the answers. But of course, like most things, prevention is better than cure. I'm going to hand you over to my colleague to talk through a study which we hope might change the outcome for cancer in PSC.
Hello again. Okay, so patients with PSC and IBD, there might be some here or relatives of people with PSC here. Patients with PSC and IBD are between a rock and a hard place potentially, so they're at risk of liver fibrosis, liver scarring, cirrhosis and all the complications of that, and they're also at risk of cancer, including cholangiocarcinoma, particularly gallbladder cancer, and those who've got inflammatory bowel disease as well as PSC, which is about 80% of them, also at risk of colon cancer as well. So it was, and there's been chatter and discussion for some time that aspirin might have some anti-cancer effects, not just liver cancer, in several other cancers. There's been lots of epidemiological data. And a few years ago, Simon, who's just spoken, and I, it was at an AMF meeting coffee break, actually. We were having a chat and said, maybe someone should just do a proper trial on it, because no one's ever done that, right? And we thought, yeah, maybe someone should, right? And then that was the end of it. And then every time we met, we said, maybe someone, no one's doing a trial of this, right? Should we, you know? And then we thought, well, maybe we should apply for a trial. So we looked at the data. Prevention is better than cure. So it took several years to form a team. That's our team, the investigator team. To start approaching funders for a trial and see what the appetite was. So I'm very grateful to everyone on that list. Some names will be familiar, but it's not just a hepatology or surgical team. Hassan Malik's there, Palak Trivedi from UK PSC, Ruth Langley, who's an internationally famous oncologist who's doing an international aspirin trial, Nick Powell, who's a colleague from Imperial, who's an IBD expert, Kath Williamson, who's a professor of women's health and cholestasis and pregnancy international expert, big PPIE involvement from PSC support and from MMF, Helen Mormont, and a high-level stats input as well. So we put together this team and had many, many meetings over a long period of time and presented this work, this proposal to many, many people up and down various specialties. The basis is this epidemiological data. So epidemiological data where you look retrospectively at patients who have a disease and those who don't, and you look for differences in their history to see, are there any differences between the two groups, people who do and don't get a disease, that might give clues as to why someone got the disease. And there's lots of studies like this done specifically in liver cancer, cholangiocarcinoma, colorectal cancer. And there's several papers that suggested that people who were on aspirin retrospectively seem to have a lower risk of these cancers. So, for example, Choi et al., published in 2016 from the Mayo Clinic, they went through their entire database of PSC patients. And they found that if people who were on taking long-term aspirin, they had an odds ratio of 0.29 to 0.35. So their chance of getting cholangiocarcinoma was 29 to 35% of people who weren't on aspirin, right? And particularly in PSC-associated cholangiocarcinoma. Simon et al. Hazard ratio of 0.57, so you're 57% less likely to get liver cancer, HCC, if people are on aspirin. Then there was a meta-analysis which looked at several other smaller studies and put all the data together, odds ratio of 0.56, so again, almost half as likely to get cholangiocarcinoma if someone was taking aspirin. Another meta-analysis found similar, and so all this retrospective data, the number 6 there, Garcia Rodriguez, a relative risk of 0.53 for colorectal cancer. So the epidemiological data on its own is interesting, but it doesn't prove anything. Right? People who were taking aspirin may well have been something else that we didn't know about that was going on. Right? So on the basis of this sort of data, one cannot recommend taking aspirin, because aspirin in patients, with anyone, but particularly in patients with PSC and inflammatory bowel disease, does have risks as well. So without investigating this properly, one cannot simply say take aspirin. But there were no proper randomized controlled trials in aspirin, except there's been one, the CAP2 trial, which was done in patients with Lynch syndrome, which is similar in the sense that these are young patients who have very high risk of cancer, particularly colon cancer. And Byrne et al. As a trial of aspirin versus placebo in patients with Lynch syndrome for several years, and the chance of getting colon cancer went down by 47%, hazard ratio of 0.63. And that changed the guidelines in Lynch syndrome, which now say offer aspirin. Right? But that was a proper randomized controlled trial that said the cancer reduction risk was achieved and safe in that patient. These are not patients who have liver disease. And there's also some, going back to the epidemiology data, that suggests that even after someone's being diagnosed with cholangiocarcinoma, if they're on aspirin for some other reason, they seem to have better survival. Again, that's soft data rather than hard data. Now, so why might aspirin do this, right? Is there any scientifically plausible, biological plausibility about how aspirin may reduce carcinogenesis? Well, there are several theories, inhibiting COX-2, platelet aggregation, activation of things like NF-kappa B, enhancing the immune surveillance of cancer, upregulating genes that help fight tumors, stabilizing repair proteins that fix mutated DNA. So this is just a snapshot. There's a whole literature on how aspirin may do it. So we've hypothesized that aspirin may reduce PSC, risk of cancer in PSC, with a safety profile. Now, the problem is, right, doing this, it all sounds great. So, well, just do a trial, right? But then you need to then decide how many patients you're going to need and how you're going to do that. And these trials take years and they cost millions. And the problem with doing trials like this, in aspirin, there's no pharma companies lined up to say, oh, we'll give you 10 million or 5 billion to do an aspirin study. There's no selling point for aspirin, right? So, but you can't just at the same time say to people, just your patient, just take aspirin, because you might harm them, because you don't know actually whether you're really giving them benefit or not, right? So there's not many funding opportunities to do something like this that would cost a lot of money. So it would cost millions. So we designed a trial, investigator-led, so it's not funded by pharma. It's run by the investigators, a phase 3 trial, where patients will be given either aspirin or a placebo. It will be multi-center, so we're going to need 40, 50, 60 hospitals around the country providing patients. Randomized, double-blind. 2 out of every 3 participants will get aspirin. So there's 2 in 3 chance of getting aspirin. When we did the power calculation, we're going to need over 900 patients we need to try and recruit, which is a lot, when the incidence of PSC in the entire country is probably less than 10,000, right? So we need like 1/10 of all the patients in the country, right? Which is quite a big ask. So we've said it will take 5 years to accrue patients. We would make sure that both groups, aspirin and placebo, are balanced or stratified for the level of fibrosis or cirrhosis they have. They have to be 12 months from the diagnosis of PSC, because sometimes they've already got cancer at the early stage, and that's led to their diagnosis of PSC. So we want to make sure that they're cancer-free at the point of entry, otherwise you're not going to prove or disprove your hypothesis. The primary objective of this trial is to investigate if patients with PSC and IBD, if low-dose daily aspirin reduces cancer risk and safely doesn't cause liver decompensation. What effect does it have on anything on the need for liver transplantation, because patients with PSC sometimes need that. And the participants will have to take aspirin or placebo for 5 years, because that's how long we think we'd need to prove that it's safe and tolerable and whether it's effective. In parallel, we would like to collect samples at these 6 monthly intervals for a biorepository of urine and serum. And if this works, if we can pull this off, we will have a unique biorepository that is unparalleled anywhere in the world of 1,000 patients with PSC with urine and serum collected every 6 months for 5 years. Some of whom will get cancer, some won't, some will get response treatment, some won't, some will get liver failures. And that would be an amazing biorepository for everyone. That's not just for, my pet projects or Simon's pet project. That would be open to everyone. So these would be our primary endpoints: hepatobiliary cancer, gallbladder, including high-grade dysplasia, and cholangiocarcinoma, HCC, particularly colorectal. We also want to make sure that there's no effect or adverse effect on liver transplantation and overall survival or cause mortality. Secondary endpoints that are important, clinically relevant, are the risk of gastrointestinal bleeding, which is a risk with aspirin, particularly if someone has cirrhosis, cholangitis, IBD flares, so patients with IBD, to make sure that the aspirin low dose is not causing flares in their colitis. That part of that includes severe inflammatory bowel disease that requires surgery. So when we crunch the numbers, we need 774 patients to complete this. Assuming a 15-20% dropout rate, we would aim to recruit over 900 patients. And we're basing that number on the event rate of these cancers and things, which is based on Palak Trivedi's team's epidemiological work, which is published in Gastroenterology recently. And Palak is part of this team, very grateful to him and his team for their data. So we aim to recruit 968 patients. That's a big ask, right, in the UK, when there's some 7,000, 8,000, 9,000 people in the country with the disease. But this is a young group of patients. They're intelligent, they're savvy, they are highly motivated. Already, almost 3,000 have already donated research samples to UK PSC's biorepository, and we have ethical permission to approach them. Not all of them will be eligible. And when we costed the trial, it comes to over £5 million. That's a lot of money to ask for, right? But we were awarded the trial from Cancer Research UK. We were awarded the funding, but it's based on annual recruitment, and it includes a 12-month feasibility. So we will get all the funding to do the trial if we can recruit. These are the inclusion and exclusion criteria. Just to talk about the PPI group, who've been amazing. So Martine and her team from PSC Support, Helen from AMMF, without which I don't think we would have got this grant, because they gave us a great amount of guidance in writing up the proposal. Every aspect of the trial was discussed with our colleagues here, including the how many people to randomize, to what, patient information. As part of the proposal, PSC Support did an actual national survey of patients with PSC to see and find some really important things. Firstly, that the vast majority of people believe it is important, not surprisingly, to reduce cancer risk. But importantly, for this trial to get through, that 86% of PSC patients said they would want to take part in the study, even though it's 5 years. And very importantly, 87% are not already taking aspirin for some other reason, right? So this is a flow chart just to say what I've said in another way. So and then the idea, if we can do this and pull this off, then the biorepository allows lots of potential future translational work. So looking at things like liquid biopsies, predictive, prognostic, etc. We haven't been funded to do the basic science stuff, but if we can get this ball rolling and start recruiting samples, then we can apply in future for more basic science projects. So it's a big grant. We will get all the money incrementally if we recruit. The grant was activated, well, the grant, the Cancer Research UK are funding this, and they released the money in January. We are writing up the protocol. We reckon we're going to need at least 50 centres from around the country, and we hope to start recruiting our first patients by the end of the year. So start thinking about, for those of you who are patients, start thinking about this. For those of you who work with patients with PSC, start thinking about patients who you think you might want to get onto it. And for basic scientists among you, start thinking about what we could do with those samples. Thank you very much.